So let us talk about the symptomatology of the cardiovascular system disorders. The cardiovascular system comprises of certain cardinal symptoms of the patient. These include breathlessness or dyspnea or shortness of breath, chest pain, palpitations, syncope and presyncope, as well as edema. Plus, there are some etiology-specific manifestations like fever and sore throat, etc. So now assessing breathlessness in the patient. What are the objectives? 1. To differentiate between cardiological and respiratory origin of breathlessness, and 2. To identify the underlying disease that is causing the breathlessness in the patient. So breathlessness. What are the history points that we must take to understand and reach our objectives? 1. Onset, duration and progression. Sudden onset breathlessness is usually suggestive of acute heart failure, which is a cardiological cause, and respiratory causes include acute exacerbation of obstructive airway disease or AEOAD, pneumothorax, pulmonary embolism. Gradually developing breathlessness over few minutes, hours, or even days is suggestive of pneumonia, obstructive airway disease, pleural effusion, and chronic heart failure among the cardiological causes. Exacerbating and relieving factors. These include postural change and relationship with exercise and talking or speaking. So, if the breathlessness is relieved on sitting upright, it is called as orthopnea and is suggestive of pulmonary edema. If the breathlessness is relieved on lying down, it is called as platypnea and is suggestive of pulmonary embolism and hepatopulmonary syndrome. If the breathlessness is relieved on turning towards the affected side, it is called as strepopnea and seen in cases of pleural effusion. If the breathlessness is aggravated on exercise or exertion, it is suggestive of an underlying cardiac cause and it is classical of congestive heart failure or CHF. If it is aggravated with talking or speaking, then it is suggestive of an underlying respiratory cause. Now you also have to ask about the timing, which includes both seasonal as well as diurnal variation and associated symptoms like cough, wheeze, sputum production. Now, if there is a seasonal variation of the breathlessness, that is, it is basically aggravated during the winters, such a case is suggestive of asthma. If there is a nocturnal aggravation of breathlessness, it is suggestive of an underlying heart failure, which is also termed commonly as paroxysmal nocturnal dyspnea. Nocturnal aggravation of breathlessness is also seen in asthma. In a case of paroxysmal nocturnal dyspnea, the patient suddenly wakes up at night due to breathlessness. He sits on the bed with his feet dangling down, walks around the room, goes towards the window to get some fresh air, and soon becomes normal again, after which he returns to bed. This episode classically is termed as paroxysmal nocturnal dyspnea. If this breathlessness is associated with cough, wheeze, and thick and white sputum production, it is suggestive of an asthma. However, if it is associated with pink frothy sputum production, it is suggestive of a pulmonary edema, which is usually due to an underlying heart failure. If there is history of sudden episodes of breathlessness that is relieved on squatting position, it is suggestive of an underlying congenital heart disease and is a feature that is classical of petrology of Fallot. Now assessing chest pain. What are the objectives? 1. To differentiate between cardiological and non-cardiological causes of the chest pain. And second, to point towards the probable underlying cause and also the severity of the chest pain. Now any pain is assessed based on the Socrates scale. Chest pain is no exception. Let us see the points in the Socrates scale. S stands for the site. It can be a retrosternal pain or a central chest pain. It can be a lateral chest pain, or some patients may also complain of a migratory chest pain. Retrosternal chest pain is suggestive of a cardiological cause or a GI cause. Chest pain that is lateralized to either the right or the left half of the chest, it is suggestive of an underlying respiratory cause and occurs due to pleuritis. Migratory chest pain is usually due to a musculoskeletal cause, that is costochondrite. Next is the onset. The onset can be acute or sudden, and it can be gradual. If it is a sudden onset chest pain, you must ask about history of chest trauma. Acute or sudden onset of the chest pain is usually an ischemic chest pain unless there is a history of trauma associated. If there is a history of trauma, the physician must rule out whether there is any chest wall fracture or development of pneumothorax, in which case there will be an association of sudden onset severe breathlessness along with the chest pain. Third C stands for character. The chest pain can be compressive or heaving chest pain. It can be a burning one, or it can also be a sharp stabbing pain. Compressive retrosternal chest pain is suggestive of an ischemic chest pain and occurs commonly due to angina. Retrosternal burning pain is suggestive of gastroesophageal reflux disease or GRD. If there is a sharp stabbing chest pain, it is suggestive of pleuritis or pericarditis. The pleuritic chest pain is located in the lateral halves of the chest and is aggravated with respiratory movements and associated with cough. Whereas the pericardial chest pain is a sharp stabbing pain in the center of the chest which is relieved on bending forwards. The R stands for radiation. Whether the pain radiates towards the inner aspect of the left arm, jaw, or epigastrium, or it can radiate along a particular dermatome. If there is a radiation of the chest pain to the inner aspect of the left arm, jaw, or epigastrium, it is a ischemic chest pain or ischemic cardiac pain. Whereas if there is a burning pain radiating along a particular dermatome, the physician must check the skin of the patient where he can notice the presence of painful skin blisters, and if fever is also present, it is suggestive of an underlying herpes zoster infection. Associated symptoms: water brush, dysphagia, palpitations, sweating, nausea, vomiting. So if water brush or dysphagia is associated, it is suggestive of a gastroesophageal reflux disease. Palpitations and other symptoms as mentioned above is also suggestive of an ischemic chest pain. Usually it is a case of a myocardial infarction. Now, T stands for timing, which includes duration since onset, and you also need to ask about the course, that is whether it is increasing or decreasing, and the pattern. If the chest pain is episodic chest pain, then the duration of each episode is also to be mentioned. And if the chest pain is a continuous chest pain, then any change in severity over the time is to be asked for. Exacerbating and relieving factors. In that, you have to ask about the association with exertion, food intake, any change in posture, breathing, coughing, or sneezing. Does the pain occur at rest? And is the pain relieved on stooping forward? So, exertional chest pain is suggestive of an ischemic cardiac pain. It is also very important to quantify the amount of activity causing the chest pain and to note the change in exercise threshold over the time. This indicates the progression of the disease. If ischemic chest pain occurs at rest, it is suggestive of an acute coronary syndrome, the most common of that being the MI. Now, if the pain is related with food intake, that is, it is either increased or decreased by food intake, it is suggestive of a gastroesophageal reflux disease or even peptic ulcer disease, for that matter. Pain, if it is increased in breathing, coughing, and sneezing, and it's a lateral chest pain, is suggestive of a pleuritic pain. If the pain is in the center of the chest, sharp stabbing pain that is relieved on stooping forward, it is suggestive of a pericarditis. And if the pain is aggravated with certain specific postures or movements, it is suggestive of musculoskeletal chest pain. In musculoskeletal chest pain, sometimes you may even find tenderness over the chest wall on palpation. And the S stands for severity. In case of ischemic cardiac pain, the severity of the chest pain can be assessed by the NYHA classification, that is the New York Heart Association classification, which is explained in a later slide. Now, palpitations. In palpitations, the target is to understand whether it is a ventricular arrhythmia or it is due to supraventricular arrhythmia. The question has to be on the pattern. Is it regular or irregular? Intermittent? If it is intermittent, then you have to ask about the duration of each episode, or is it persistent? You should ask for the precipitating factor. The usual precipitating factor is exertion and associated symptoms like syncopal attacks, post-palpitation diuresis, and TIA or ischemic CVA. Now, if syncopal attacks are present, then it is suggestive of a ventricular arrhythmia. Post-palpitation diuresis is suggestive of a PSVT, whereas association with a TIA or ischemic CVA is suggestive of an atrial fibrillation. In an atrial fibrillation, there is stasis of the blood in the chambers of the heart, which results in development of intracardiac thrombi, and the embolization of the thrombi result in embolic strokes in the patient. Therefore, TIA or ischemic CVA is common in patients of atrial fibrillation. Now, assessing syncope and presyncope. What are the objectives? The first question to be answered is it really a syncope? Because there are many syncope mimics, two significant of which include seizures and transient ischemic attacks or TIA. If it is a syncope, then we need to determine what is the cause of the syncope. Is it a neurogenic cause, which is also called as vasovagal attack? Is it a cardiogenic cause? Or it is simply due to a postural hypotension? Now, syncope and presyncope. Let us understand the definition of syncope. Syncope is defined as sudden onset loss of consciousness. In such cases, you have to ask about what is the duration and the frequency of previous such episodes. Associated symptoms, which includes asking of the symptoms that happen during or after the attack. In a syncope patient, throughout the episode until recovery, the patient has no consciousness. So, it is very imperative for a witness to be present so that you can have a proper history. The associated symptoms are to be asked only from the witness. The symptoms that are to be asked include cyanosis, frothing, injuries and tongue bite, gross abnormal movements, pallor, sweating, urinary fecal incontinence, history of post-recovery paralysis, whose duration usually to be asked is less than 24 hours, and confusion. Now, if cyanosis, frothing, injuries, and gross abdominal movements are present, it is suggestive of seizure. It also has post-recovery confusion and drowsiness. Presence of pallor, sweating is suggestive of syncope. Post-recovery in syncope, the patient is clear-headed. Now, both seizure and syncope is incontinence, so incontinence is not a differentiating feature between the two. If there is a post-recovery paralysis, then that is suggestive of a transient ischemic attack. Precipitating factors like exertion, prolonged standing, emotional stress, overcrowded place, or sudden standing. If the precipitation is by exertion, then it is usually a cardiogenic syncope. If the syncopal attack is precipitated on prolonged standing, emotional stress, or overcrowded place, it is a neurogenic syncope or a vasovagal attack. Whereas if it is precipitated on sudden standing, it is a case of postural hypotension. Now, relieving factors, which includes lying down. If lying down is a relieving factor, then it is suggestive for neurogenic syncope or even a case of a postural hypotension. Presyncopal features are to be asked for, which includes autonomic symptoms like nausea, sweating, and palpitations, postural symptoms like dizziness, lightheadedness. Now, autonomic symptoms, if they are present like nausea, sweating, palpitations, then this is suggestive of neurogenic syncope or a vasovagal attack. If there are postural symptoms like dizziness, lightheadedness, then it is suggestive of a postural hypotension. Therefore, again stressing on the fact that during syncopal conditions, the patient has a transient loss of consciousness. So, presyncopal features or presyncopal symptoms can be stated by the patient. However, in order to assess the events that occurred during the syncopal attack, the practitioner must take the relevant history from a witness. Now, assessing edema. The objectives include differentiating between the local and systemic causes of edema and also determining the cause of edema. Is it a cardiogenic cause, a nephrogenic cause, or a hepatogenic cause? Now, edema may be localized or systemic. It depends on the distribution. The questions to be asked are onset, duration, and progression. The onset of edema is usually gradual. Sudden onset of edema can be traumatic cause and allergic cause like angioedema where the face lips, etc. Cardiogenic edema first appears in the lower limbs and thereafter progresses to the face at a later stage. Early morning facial and periodically suggestive of a nephrogenic cause. Site or distribution. In case of paired structures like pleural cavities, feet, you have to ask if it's a unilateral cause which usually indicates a localized cause or is it a bilateral involvement which indicates an underlying systemic cause. Now, the distribution tells you whether it is a localized edema or a systemic edema. Local causes include trauma, infection, whereas systemic causes can be nephrogenic, cardiogenic, or hepatogenic. Other rare systemic causes include malnutrition, angioedema, etc. Now, is the edema cardiogenic, nephrogenic, or hepatologic? Associated symptoms: decreased urine output, hematuria, jaundice, or severe symptoms of chest pain, shortness of breath, palpitations. If there is a decreased urine output and hematuria, it is suggestive of an underlying nephrogenic cause. If jaundice is present, it indicates an underlying hepatological cause. Whereas severe symptoms of chest pain, shortness of breath, and palpitations are suggestive of an underlying heart failure. Now, after the cardinal symptoms, you have to ask about the etiology related manifestations from the history. Important history related to this include history of fever, joint pain, rash, visual blurry, color change in nails and palms, which is suggestive of infective endocarditis. Infective endocarditis is usually considered as a complication of a valvular heart disease. History of intermittent claudication of the limbs is to be asked for if ischemic chest pain are present. History of fleeting joint pain, sore throat, subcutaneous nodules, skin discoloration, and long-term injection in the buttocks every 3 weeks is suggestive of a history of rheumatic fever. History of rheumatic fever is very important in a patient of valvular heart disease, as rheumatic heart disease is very common in India. It is an endemic region for rheumatic heart disease or rheumatic fever. History of diabetes, hypertension, TB contact, STD exposure, or cardiothoracic surgery also stands very important. History of drugs, which includes antidiabetic, antihypertensive, or blood thinning medications, or even monthly blood tests, is important. Family history of cardiovascular diseases to rule out the congenital causes or the genetic causes of cardiovascular diseases. Now, last but not the least, you have to assess the severity of the symptoms, that is, chest pain, palpitations, or shortness of breath. And for that, we have a New York Heart Association classification, which includes 4 classes: Class 1, 2, 3, and 4. In Class 1, regular exercise does not result in symptoms, only strenuous exercise causes the development of chest pain, palpitations, or dyspnea. In Class 2, there is a slight limitation of the physical activity. Ordinary physical activity can cause fatigue, palpitations, or dyspnea. In Class 3, there is heart failure with limitations of physical activity. There is no symptoms at rest, but however, mild activity results in fatigue, palpitations, or dyspnea. And Class 4 is heart symptoms at rest. The patient is unable to engage in any type of physical activity without a discomfort. Therefore, we can see as the grade increases, the severity of exercise limitation or activity limitation increases, and therefore, it is very important to assess the exercise tolerance in a patient of a cardiological disease. Thank you.